Okay, so it's 9 o'clock, and welcome everyone. Thank you everyone for joining once again. It's been great to share some of these cases with you. Can someone just write in the chat and let me know that they can hear me okay with the volume? Perfect, thank you. Okay, so let's get started. So for everyone who hasn't already, please go to this website at Poll Everywhere, and then you can click where you're joining from, and you can see it's quite amazing. We have people joining from all over the world today, which is great. And the other thing, so I'll be having some interactive polls during the session that you can use Poll Everywhere to answer. And as well, we have the group chat, so if you have questions related to the pathology on the slides, please feel free to use that, and we'll try and address that as we're going. So let's get started. So our first case, we actually have a gross photo. So this is a wedge resection from the lung. It's been serially sectioned. We have this cystic area here. And when I was actually grossing this case, this material actually had come out of the cystic area here. And so let's take a look at what this is here. So this is a section from the material or a structure that had kind of fallen out of the cystic area. So when we zoom down at higher power here, we can see that there's large areas of this acellular material that has a very lamellated appearance, kind of almost like you're looking at the rings of Saturn, where you have these concentric layers throughout it. Much of it is acellular, but if we move over to areas here, we can see that there's some structures. It's quite eosinophilic. We see this lining here that has a bit of a granular appearance to it. We see some areas of calcification with these concentric calcifications. We see these structures here that are multicellular, and they're composed of cells that have very small nuclei. They're quite a bit smaller than the surrounding nuclei of these histiocytes here that you can see have some foam evacuation to them. So that's the section of the material that came out of the cystic structure. And if we take a look at the section of the lung, we see this is the cystic area here. We can see a amount of fresh hemorrhage here. And then you can see once again these structures. So once again, these multicellular structures that are composed of these small nuclei, they do have these refractile structures here that you can see. Just move to a little lower power. Circle sign is always a good thing. You can see another nicely formed one here with these polarizable refractile structures here and these small nuclei. And then also these calcifications here as well. You can also see some of these similar structures into the alveolated lung parenchyma here. So we can see one of these structures here as well. And then you can see some foamy macrophages associated with it as well. Perfect. So that brings us to our first polling question. So if you go to Poll Everywhere, you should be able to answer this. What is the best diagnosis for this case? Is it perigoneumus? Is it ascaris? Is it schistosomia? Or is this an echinococcus case? Perfect. So we're getting lots of responses here. Great. Yeah, so that is the answer. This is a case of echinococcus. And so the next question is, so we had a question in the chat about, are those hooklets? Yes, so those are the hooklets that I was describing that have that refractile appearance. So great to point that out. And so the next question is, what is the definitive host for echinococcus granulosus? Is it A, dogs/wolves? Is it B, sheep? Is it C, humans? Or is it D, camels? Let's see what we got. Oh, interesting. Okay, so the answer is actually dogs/wolves. Sheep are actually the intermediate host. We'll go through the life cycle here right now. So this is a depiction from the CDC, which shows the life cycle of echinococcus. So a dog or a wolf is actually the definitive host where the full adult size worm will form. And this attaches inside the small intestine of the dog, where it will lay these eggs that are then excreted into the fecal material, which can then be picked up in an intermediate host, such as a sheep or actually a human. And then once these eggs will actually hatch inside the gut of the intermediate host, they form these oncospheres, which actually penetrate in the intestinal wall and then get into the bloodstream. And then once in the bloodstream, they can set up shop in various organs, such as the lungs, liver, or brain. And this is what they form the hydatid cyst. And that's what we actually saw in the previous section, where you often see these daughter cysts, and they have this nice lamellated appearance to the material in the daughter cyst, and you have those protoscolices that we saw that have the hooklets in them. And so we don't actually form the complete worm in humans or the other intermediate hosts such as sheep. And then how it then gets back to the definitive host in a dog or a wolf is that if the wolf were to then ingest the organs of a sheep that were infected with it, it would then get reinfected by by this, which then would attach to the intestine, form the adult worm, and then could then lay the eggs once again and repeat the life cycle of this. So humans are actually an intermediate host, similar to sheep. Great. So let's move on to the next case here. So we have a surgical wedge biopsy here of lung. And you can see it's quite abnormal, but the abnormality is somewhat patchy. And so if here is the pleural surface, you can see the abnormalities are very much focused on the pleural surface. So we just have a question from on the chat about the previous case. So the question is, were those structures scolices? So they're actually protoscolices because they're not the full worm. They're the more the juvenile form of the worm. Thanks for the question. So back to this case, we have an abnormality that's really centered around the pleura, and then it extends down into the underlying lung parenchyma. And then when we look at the background lung here, it actually looks quite normal. And another thing I want to point out is the abnormality is quite uniform as we're coming from this pleural surface. So we're not really seeing much in terms of heterogeneity, either spatially or temporally. In these areas of fibrosis, the character is really quite uniform throughout it. But you can see it's really really changing the structure of the lung here, where we're really losing the nice alveolar lung parenchyma that we see here over in normal areas. So when we look down here, we can see that the fibrosis has an interesting character to it. It looks very fibroelastotic. And what I mean when I say that is that see these squiggly lines all through here? This is the elastin, and this is what we see in a fibroelastotic fibrotic process. And this is different to the fibrosis that you typically see in some other interstitial lung diseases, which look a bit more fibrous or collagenous. This has a very fibroelastotic character to it. Perfect. So what is the best diagnosis for this case? Is it A, usual interstitial pneumonia or UIP? Is it B, PPFE or pleural parenchymal fibroelastosis? Is it C, NSIP or non-specific interstitial pneumonia? Or is it D, chronic hypersensitivity pneumonia? Great job. So this is in case of PPFE or pleural parenchymal fibroelastosis. And so pleural parenchymal fibroblastosis, or PPFE, can occur over a broad range of ages, and it has a relatively equal distribution between males and females. And radiologically, it has a very classic appearance. So this patient actually had a pneumothorax, but many patients that can often be seen in these cases. And what you see is you see this diffuse pleural parenchymal thickening that is on the order of 4 to 15 millimeters. That's more prominent within the upper lobes. And so what we see on slides is we see this upper lung fibrosis of the visceral pleura that spares the parenchyma that's away from the pleura. And as I was describing, this fibrosis has a relatively uniform character with it, with this distinct fibroelastotic nature. And so the differential for this case is a usual interstitial pneumonia, but we're really not seeing the spatial heterogeneity where we see different phases of the fibrosis. The fibrosis in PPFE looks very much more uniform. NSIP is also in the differential. However, the very focused disease around the pleura with large areas of normal lung would really keep NSIP out of the differential. And then the fibrosis in NSIP doesn't characteristically have this fibroelastotic nature. And then the last is an apical cap. So you can get fibroblastotic scarring and apical cap. They can look very similar. So really it's important to correlate with the radiology and make sure this is just not a little localized area in the apice of the lung, and that this is really a bit more of a diffuse process. Any questions about this case as we move on to the next? Okay, so our next case here, we have another surgical wedge biopsy. And then so as we zoom down to higher power, we can see we have a patchy process from this low power, where we have these more blue areas that are around some of the smaller airways. As we zoom down here, we can see we have this proliferation of relatively bland appearing cells. They do have a fair bit of cytoplasm. The nuclei, some of them have a bit of grooves or folding character to them, and they're really kind of more sheets of them all throughout. And then we also see this pigment here as well. It's a mixture of this fine yellow to brown pigment with interspersed black specks that are associated with these areas. Just want to show another slide which highlights another feature of this. So once again, we have these nodules, as well as we have some cystic spaces here as well associated with these nodules. And then when we zoom down to higher power, we can see numerous eosinophils here all throughout this lesion associated with these cells. So this nodular area, we have some pigment deposition, as well as we have interspersed eosinophils, and then these cells that have these more groove nuclei that are folded in areas as well. So the question is, what is the best diagnosis for this case? Is it A, Kaposi sarcoma? Is it B, pulmonary Langerhans cell histiocytosis? Is it C, Erdheim-Chester? Or is it D, desquamative interstitial pneumonia? What does everyone think? Okay, so getting lots of responses. Great, so this is a case of pulmonary Langerhans cell histiocytosis, or PCLH. Great job. And so to prove that, you can actually do an immunohistochemical stain for CD1A. So this is a stain for CD1A, and so this will stain these Langerhans cells, which are a form of dendritic cells. And you can see these large clusters and sheets of these Langerhans cells that make up this process. So the next question is, what is thought to be the underlying cause of PLCH, or pulmonary Langerhans cell histiocytosis? Is it A, smoking? Is it B, vaping? Is it C, inherited genetic mutations? Or is it D, alcohol consumption? Good job. So yeah, that is right. So this is a smoking-related disease. So smoking is thought to be the underlying cause of this in many cases. But these are actually can be neoplastic. And so what is the most likely molecular abnormality that we can see in a subset of pulmonary Langerhans cell histiocytosis? Is it A, KRAS mutations of G12C? Is it B, EGFR mutations of L858R? Is it C, fusions between STAT6 and NAD2? Or is it D, BRAF mutations? Perfect. So great. So in fact, you can see BRAF mutations in these cases. That V600E is the most common. So I did have a question about this case in the chat, and the question was, what is the pigment? So the pigment is very similar to smoker's pigment, and you can see a background respiratory bronchiolitis in these cases as well. So respiratory bronchiolitis is just the accumulation of this smoker's pigment. And so smoker's pigment has this character to it, where it's this fine yellow to brown pigment, and it has typically these black specks within it as well. And so this essentially just means that the patient is a smoker. You typically see this in the distal airways and the lung parenchyma surrounding that, and that's really limited to that. And a term that we use for this when we see it is respiratory bronchiolitis. So respiratory bronchiolitis is really just the presence of these pigmented alveolar macrophages that have the characteristic appearance of smokers' macrophages. It's a great question, and we'll talk a bit more about these types of pigments coming up. Okay. So pulmonary Langerhans cell histiocytosis is a clonal proliferation of these specialized histiocytes, and it's typically driven by activating mutations in BRAF or the MAP kinase pathway. I'll show you the CT in a second, but it has a characteristic appearance of small nodules and cysts. And the first line treatment for these is smoking cessation. There is some emerging evidence that BRAF inhibitors can be used in patients who have a BRAF mutation, so it highlights the importance of testing for BRAF in these cases. So this is representative imaging that I was describing. So you do have these cystic areas here. They are often described as more irregular looking cysts, and they're often associated with more nodular densities as well. So this is kind of a characteristic imaging pattern of pulmonary Langerhans cell histiocytosis. In terms of histology, it's typically centered around the bronchioles that contain these Langerhans cells, and they have this characteristic folded to groove nuclei. And eosinophils can often be associated with it, and it's a pigment that has the appearance of smokers' macrophages. An important thing is you can get burnt out pulmonary Langerhans cell histiocytosis, and this really will just appear as an airway-centered stellate appearing scar without really the characteristic Langerhans cells. And so if you see that in a long-standing smoker, it likely is just burnt out PLCH. So the last question for this case is, if we had this EM picture here, what am I trying to show here? Is it A, viral particles? Is it B, cilia? Is it C, desmosomes? Or are these D, Birbeck granules? Good job, everyone. So these are, in fact, Birbeck granules. Yes, and they do have the appearance of tennis rackets. Okay. So our next case here, we're kind of working along a similar theme. And so you can see from low power here that it looks quite abnormal. We have a kind of diffuse abnormality throughout this wedge biopsy here. And when we zoom into higher power, we can see the abnormality is really centered within these air spaces. And within these air spaces, they're really just completely filled, chock-a-block filled with these pigmented alveolar macrophages. And they once again have the appearance of smokers' macrophages with this fine pigment with interspersed black specks. There is a little bit of thickening of the septa, and it does have this more collagenous appearance to it as well. And you can see if we go all the way out, you can still see these pigmented alveolar macrophages completely filling and expanding these alveolar spaces all throughout the specimen here. No matter where we go, we see a very similar process of these abundant pigmented alveolar macrophages and this relatively uniform fibrosis that's associated with it. So in this case, what is the best diagnosis? Is it A, respiratory bronchiolitis? Is it B, desquamative interstitial pneumonia or DIP? Is it C, nonspecific interstitial pneumonia or NSIP? Or is it D, usual interstitial pneumonia? Great job. So this is a case of a desquamative interstitial pneumonia or DIP. So we'll go to the next question here. So what are the cells that are filling those air spaces? Are they squamous cells that have been desquamated? Are they B, pneumocytes? Are they C, macrophages? Or are they D, fibroblasts? Good job. So these are, despite the name of desquamative interstitial pneumonia, that's a misnomer. And that comes from before that they realized that these are actually macrophages when we had the use of immunohistochemical stains. These are actually pigmented alveolar macrophages. They are similar to the macrophages that we see in respiratory bronchiolitis. The difference is they're not just distributed into the terminal airways and distal bronchioles, but they're more expanding and diffusely involved in the parenchyma. And so what does this patient likely do? Do they A, smoke, B, vape, C, inject crushed pills, or D, are they more likely to aspirate? Good job. So that's right, that this is heavily associated with smoking. Perfect. And so desquamative interstitial pneumonia, or DIP, it's highly associated with smoking. The CT appearance does have a prominent ground glass component that's kind of admixed with normal lung, can have a lower lobe predominance. The histology, as we showed, has these large clusters and sheets of pigmented alveolar macrophages. You can also see focal giant cells within these air spaces, and you can get an associated interstitial fibrosis and inflammation. Patients typically improve with smoking cessation, and a subset of patients may need steroids. This can progress in a subset of patients as well. Perfect. In this case, I just wanted to bring up an important point, I think, of when we're talking about pigmented material in air spaces. And so, in contrast to the previous case of the smoker's pigment associated with cigarette smoking, this pigment looks a little bit different. It's a much more of a deeper brown color. It's a little bit chunkier. Um, has a bit more of a chunkier appearance to it, and it's quite coarse as well. So there's a question in the chat about, is this a proliferative process going on with the macrophages? If so, does it predispose to neoplasms? So in regards to DIP, so this is thought to be a reactive process in response to that, the reactive proliferation of them. And I don't believe there's an increased incidence above the background incidence of smokers, but these are typically heavy smokers in DIP, so they're probably already at a high risk of lung cancer. So another question here, does the character of the pigment in RB and DIP differ on the type of material smoked, filtered, filtered cigarettes, tobacco versus marijuana, etc.? So yeah, so we're actually going to talk about that right now. So this pigment here has a bit more of a coarse appearance to it. So let's go to the question of what people think this is. So what, in this case, what do you think the patient most likely does? Do they A, vape, B, smoke cigars, C, smoke cigarettes, or D, smoke marijuana or cannabis? Yeah, so a bit of a mix here. Yes, this is actually the pigment you see in characteristically with cannabis use. It tends to be a more coarse pigment that has more of a brown character to it, more of a deep brown character. It can look a lot like hemosiderin as well, which I'll show shortly. So it can be challenging to identify it, and sometimes you rely on history, and that's the coarseness of it might relate to the fact that a lot of the cannabis cigarettes or cannabis material that's smoked does not have filters, so you get these larger pigmented material, and it often has this more oily component to it as well. And so it does look a little bit different in patients who smoke marijuana. And then just last for comparison here. So this is actually a different pigment here, and you can see that it looks different than both the smoker's pigment as well as the pigment that you see in cannabis smokers. It has, once again, this more chunky appearance, but it's larger globules of material, and you don't really see that kind of background of fine kind of staining. It has this, and it has this kind of lighter brown character to it as well, and it's filling these alveolar spaces here. So what do you think the cause of this pigment is? Is it A, hemosiderin? Is it B, smoker's pigment? C, marijuana pigment? Or D, melanin pigment? Perfect. So this is in fact hemosiderin. So this is showing the different pigments that we can see in respiratory bronchiolitis. The cigarette, let's just go back to review because there's a number of questions about it. So I'm just going to go back to our case here, our Langerhans cell case. I think this case is actually good because I think you can see a few types of pigment in this case actually. So here, so this is the more characteristic pigment that you can see in cigarette smokers, where you have this fine yellow to brown, very light staining pigment with these interspersed black specks. And so this is the pigment associated with smoking. But then in other areas, this is all kind of smoker's pigment. Some of it can get a bit a more coarse pigment. So this is more like the pigment that you can see in marijuana smokers. but it doesn't really have that kind of golden brown globular staining that you see in hemosiderin. So this patient looks like they actually both have characteristic pigment from both cigarette smoking as well as marijuana or cannabis smoking, and so this patient potentially used both. It's not a complete, perfect analysis of it, but you can recognize differences in them. But it is important to correlate with history. Good job. So I think the next, oh, it's a question to show the hemosiderin again. Sure, just go back to that, and then we'll move forward. So here's the hemosiderin again. So you can see that it has this kind of lighter brown color. It has this very globular look to it, and you don't really see in the background of the fine yellow pigment. So this is a hemosiderin pigment as well. Okay, and so last question about the pigment, and then we'll move on, is true or false? An iron stain can be used to differentiate between hemosiderin and smoker's pigment. What does everyone think? Can you just do a Pearl's Prussian blue and that'll tell us, and we don't have to worry about making this distinction? Good job. So it actually is false. You can actually get positive iron staining in both hemosiderin and smoker's pigment. So an iron stain actually doesn't help exclude one or the other. So you really have to do it based on morphology. And so just to recap, let's talk a bit about smoking-related lung disease because it could be kind of confusing. So the respiratory bronchiolitis is really just the presence of pigmented alveolar macrophages that are associated with distal airways. And this is just the presence of essentially smokers. And then when you get to desquamative interstitial pneumonia, you really have diffuse amounts of these pigmented alveolar macrophages that can often have a much lighter staining for the pigment, and it expands and fills these alveolar spaces way out into the alveolar lung parenchyma. There's also an entity called smoking-related interstitial fibrosis, and that's fibrosis of the interstitium that we saw in our case of DIP. It has a very collagenous appearance to it. Maybe next time I'll show a case of that as well. So yeah, let's keep moving ahead so we can finish. So here's another case here. So we have these surgical wedge biopsies again. So let's go down to the green circle signs. That's usually a good place to go. And so this is a bit of a review from last time to see if people picked up some things from last time. But within these alveolar spaces here, we have this loose proliferation of fibroblasts that kind of have this mucopolysaccharide-rich character to them. You can see nicely here it has a bit of this dumbbell type appearance where it kind of expands out here, narrows down, and expands out again. And then the other thing that you can see here is that we do have these foamy macrophages associated with the air spaces here. And there's also some foamy pneumocytes as well associated with some of these areas. We're not really seeing much in terms of smoker's pigment, so there's no real respiratory bronchiolitis. This patient's likely not a smoker of cigarettes. We're not really seeing that coarse pigment either. Perfect. So the question for this case is, what's the best diagnosis for this case? Is it A, acute lung injury with organizing pneumonia? Is it B, acute lung injury with diffuse alveolar damage? Is it C, aspiration? Or is it D, exogenous lipoid pneumonia? Let's see what everyone thinks. Perfect. Yes, this is an acute lung injury with organizing pneumonia. Good job. And this is actually a case of a vaping-induced lung injury. So this was an article that was published in New England Journal from the group of the Mayo Clinic, as well as highlighted in the New York Times. So this is just one of the articles in the New York Times. It's always nice to see pathology in the literature, especially in a publication such as big as the New York Times. It's cool to see an H&E image in print in the New York Times. But so essentially what they saw is features of acute lung injury, and they can have these foamy macrophages with them, as well as foamy pneumocytes. But this all got a little bit confusing when this first came out because it had been initially characterized as a lipoid pneumonia based on these BAL stainings here, where they did these oil red O stains to say that it was actually the lipid that was coming from it. But it's actually not an exogenous lipoid pneumonia. And I'll show a case of exogenous lipoid pneumonia coming up. But it's really just this acute lung injury, and these macrophages likely relate from more endogenous or obstructions from this. And then in terms of what caused this, I won't get into all the details, but it really seems it was centered around this vitamin E, which was used as a cutting agent in to dilute the product in these vaping products. And so it was really introduced earlier on in the spring, and then you see this peak of cases of vaping-induced lung injury, and it really kind of then peters off once it then was reported in the literature that the cause potentially was vitamin E, and this was kind of removed as a cutting agent for it. And then there's an interesting paper that came out of the literature about how might this be happening. So I'm not a chemist by any means, but basically, suffice to say, this vitamin E basically gets converted when it goes through this high temperature treatment that produces these ketones that are these very reactive products that can cause damage to the lung and likely cause this chemical burn type injury or this acute lung injury that we described. And then just to show an example of what an exogenous lipoid pneumonia looks like. So this is very different looking, where we're seeing these kind of coarse vacuoles of material here, and then it's present in both the air spaces as well as the interstitium. And then these macrophages here, you can see it's not the fine little tiny vacuolation that we saw last time, but there's these coarse large vacuoles of these macrophages that are present throughout. The lipid material does get washed out so that we largely just see these holes in the spaces, but you can also see these large macrophages here that have this coarse vacuolation. They often have this fine pigment, and you can get a scattered giant cell reaction as well. So I think I gave that answer away. This is a case of an exogenous lipoid pneumonia. It's not an endogenous lipoid pneumonia, so those are more characterized as what we saw previously with the finely vacuolated macrophages within the alveolar spaces. And so what do you think this patient most likely has a history of if they have an exogenous lipoid pneumonia? Is it A, constipation? Is it B, vaping? Is it C, diarrhea? Is it D, cough? Yeah, good. So you got it. So it is constipation. So often this is actually caused by people who aspirate mineral oil that they take for constipation. And so you can get this caused by many things, including mineral oil, Vicks VapoRub if you inhale it. So people who put that underneath their nasal passageways, they can actually aspirate some of that, and that can also cause a lipoid pneumonia. So next question, what occupation might this person have? Are they A, fire eater / fire breather? Are they B, a firefighter? Are they C, a deep sea diver? Or are they D, a pathologist? Good job. Yeah. So that you can see this in people who are working as a fire eater or breather, where they will use these hydrocarbons to then spray out of their mouth and light on fire. And if they aspirate some of this, it can end up in their lungs as well, and they can get an exogenous lipoid pneumonia. Thankfully, I don't think there's many cases of pathologists who have exogenous lipoid pneumonia, but I guess if you inhaled too much paraffin, you could. So just as a summary, so lipoid pneumonia, you can have both an endogenous or an exogenous. Endogenous pneumonia, also known as a post-obstructive pneumonia, you have this accumulation of foamy, finely vacuolated macrophages that are primarily in the alveolar spaces, and you don't really have much fibrosis. Whereas an exogenous pneumonia is from the inhalation of oil or other lipid-rich substances, and you get these variably sized, coarse lipid vacuoles within the interstitium and macrophages. You can also get a foreign body giant cell reaction and fibrosis. So this is just another case here. So we'll follow the green arrow sign here. Usually a good place to start. So once again, see this acute lung injury with some organizing pneumonia. And then as we move around, see once again these foamy macrophages as well. And as well, you start to see some foamy pneumocytes as well. And the foamy change is actually really quite prominent in this as well. And so you can see that there, see that there. Yeah, so we have acute lung injury and this really prominent foamy evacuation of both the macrophages as well as the the pneumocytes. And so what drug do you think this patient might be taking? Do you think it's A, hydroxychloroquine? Do you think it's B, amiodarone? Do you think it's C, methotrexate? Or D, bleomycin? Good job. So this is in case of amiodarone. I think people may have seen the file name of it as it popped up, but this is a case of amiodarone. And so amiodarone is an antiarrhythmic agent. It's typically used in congestive heart failure as well as ischemic heart disease. So histology, you can often see an acute lung injury spectrum. And the other thing you see with this is these abundant intraalveolar foamy macrophages and pneumocytes. And these foamy cells are really just a marker of exposure to the drug. They don't actually indicate toxicity. And there is a characteristic EM feature as well, where they show these atypical lamellar bodies that have a laminated appearance with myelinoid inclusions. And I bring this up because the appearance of the amiodarone has a very similar appearance to the case we saw with the vaping-induced lung injury, with these foamy macrophages as well as pneumocytes. That suggests that there could be a similar process going on with issues with the surfactant, which is actually what's causing these atypical lamellar bodies. Great, okay, so let's keep forging ahead. So this case, you can see from low power, we do have a cystic lesion here. And then it's quite prominent here. And then you see some smaller cysts around here as well. So let's take a look at this cyst as well and see if we can figure out what's going on here. So we have this cyst, and then in the wall of this cyst, we have these more spindled cells that are kind of proliferating in the wall of the cyst. Some of them almost have a smooth muscle type appearance to them, as you can see here as we go throughout it. Just going to move on to one of these other cysts here, where you can also see the same kind of proliferation of these spindle cells kind of around these dilated cystic spaces. They're kind of patchy throughout this specimen here. So what do you think the best diagnosis for this case is? Is it A, LAM or lymphangioliomyomatosis? Is it B, Birt-Hogg-Dube? Is it C, lymphocytic interstitial pneumonia? Or is it D, pulmonary Langerhans cell histiocytosis or PLCH? Perfect, great job everyone. So this is a case of lymphangioliomyomatosis or LAM. Yeah, so good point, John. I'll bring up that in a second about the gender of the patient. But first, if you're going to do some immunohistochemistry, which of the following would be positive LAM? So I've given you a number of choices in this. So is it A, calponin, B, smooth muscle actin, C, melon A, D, HMB45? Is it E, all of the above? Is it F, A and B only? Or is it G, C and D only? Okay, good. So it is all of the above. You can get staining for both smooth muscle markers as well as melanocytic markers. So calponin, smooth muscle actin, as well as melon A and HMB45. So it is all of the above. And what clinical history do you think you might get for this patient? So if they had a pleural effusion, what would be the characteristic type of pleural effusion would you expect in this patient? Would it be A, a hemorrhagic effusion? Would it be B, an infectious, like an empyema? Or would it be C, a malignant effusion? Or would it be D, a chylous effusion, which typically has a white milky appearance to it? Good job. So D is the correct answer. It is a chylous effusion, and it's due to obstruction of these lymphatic spaces associated with this tumor or this condition. And so what's the genetic syndrome that's associated with lymphangioliomatosis? Is it A, familial adenomatous polyposis or FAP? Is it B, Gardner syndrome? Is it C, Carney? Is it D, tuberous sclerosis? Good job. So it is tuberous sclerosis. That is the genetic syndrome associated with LAM. So LAM is derived, so you get these abnormal proliferation of these cells that are these perivascular epithelioid cells. They're spindled epithelioid cells, and then as we discussed, they co-express these smooth muscle markers and melanocytic markers. And so there's a characteristic history in these, as John Kale pointed out. These are classically seen in women of reproductive age, and it's extremely rare to see this in men, except in patients who have tuberous sclerosis. In the histology, we see these nodules, those plaques of spindle cells with this kind of fibrillary cytoplasm that's surrounding these dilated air spaces. So this is a classic case of Lamb. On radiology, has a classic appearance as well, where you see these thin-walled cysts here, and they actually are varying in size. So you can see smaller ones, bigger ones, and they're surrounded by some areas of uninvolved long parenchyma. This is actually a quite severe case as well. So this is just another image from Radiopedia where it shows the differential of cystic lung disease, where you between Lamb, where you have these cysts of varying size throughout the lung. LIP can actually also cause cysts as well. You typically see less of them, as well as pulmonary Langerhans cell histiocytosis, where we described before. You have these irregularly shaped cysts, and then they have often solid nodules. So someone brought up an important point, which I think will lead me next to my next question. So if this patient has a history of tuberous sclerosis, what tumor would you most likely expect in the kidney? Would it be A, a chromophobe, B, angiomyolipoma, C, collecting duct carcinoma, or D, oncocytoma? Great job. So yeah, so these are characteristics associated with angiomyolipomas as well. So that's what you characteristically expect in patients with tuberous sclerosis. Good job. So moving on to our next case here, we once again have these cystic areas here. So we see the cysts throughout this lung parenchyma. When we're looking at the walls of the cyst, we're really not seeing the smooth muscle proliferation or nodules or anything that we saw last time in the case of Lamb. And we're not really seeing much in terms of smoking-related changes. Maybe a few pigmented alveolar macrophages, not a ton. And this doesn't really have the appearance of emphysema. There's these relatively well-formed cysts in the middle of otherwise relatively normal lung parenchyma that are distributed throughout it here. Some of them are a bit closer to the pleural surface. You can see them all throughout here. So these relatively nondescript cystic areas throughout the lung specimen here without really any abnormal spindle cell proliferation associated with these cystic areas. So what do you think the best diagnosis in the case is? I'll give you the hint that this patient also has both renal and skin tumors. And so what do you think the best diagnosis is? Is it A, lymphocytic interstitial pneumonia? Is it B, Birt-Hogg-Dube? Is it C, lymphangiomatosis or LAM? Or is it D, pulmonary Langerhans cell histiocytosis? Good job. So this is a case of Birt-Hogg-Dube. And so Birt-Hogg-Dube, so the radiology can be really important in these cases. And so once again, we see cystic changes. They tend to be more basilar predominance, where they're down here at the bases of the lung, and they can often be just right off the pleural surface. And so this is different than the appearance that we saw in Lamb, which had variably sized cysts throughout the lung, or pulmonary Langerhans cell histiocytosis, where we had these irregularly shaped cysts with more nodular appearance to it. So correlating with the radiology can be really important with it. So the next question is, what skin tumors are actually seen in these patients with Birt-Hogg-Dube syndrome? Is it A, basal cell carcinoma? Is it B, Merkel cell carcinoma? Is it C, fibrofolliculoma? Or is it D, syringoma? Good job. So yeah, in fact, the tumors you do see in these patients are fibrofolliculoma, and that characteristically is in Birt-Hogg-Dube syndrome. Good job. So this is a interesting case. So we have a section of lung here. So we have some more central sections. We see some large airways here, and then we see these large pulmonary vessels here. And then there's this material inside these vessels here. The material is composed of these cells with this very elongated fibrillary type stroma. These other cells here. I won't say too much about them because I don't want to give away the diagnosis. You can see here that has a relatively interesting arrangement and structure to them. You see it throughout here. There's another vessel here that has similar appearing cells within this vasculature here. It's a bit of an interesting case. So what do we think of the diagnosis? What do you think the best diagnosis is? Is this a metastatic tumor within these large vessels? Is it a teratoma that we're seeing? Is it embolized brain material second to trauma? Or is it D-intimal sarcoma arising in these vessels here? Good job. So yeah, you guys got it. It actually is embolized brain secondary to trauma. So there's been a series of case reports. This can happen both in newborns as well as in older patients who have trauma that actually you can get cerebellar tissue that actually embolizes to the lung. That's from head trauma that can get embolic into the vessels in the lung. Okay. We're nearing the end. And so here we have a mediastinal lesion. So we can see here, this is some normal appearing thymus. So we have both the medullary areas in the thymus, so cortex and medullary areas. And then we have these Hassel's corpuscles, which are these more squamous appearing islands that are present in the medullary areas. Some normal thymus. Zoom back out to low power. And then we do see that there's these fibrous bands kind of intersecting throughout. It appears relatively well capsulated. And then when we zoom down to higher power, we see a mixture of some chronic inflammatory cells. Then we see these really large, atypical appearing cells that have these prominent macronucleoli. Some of them are binucleated here. Let's see here. And as well as associated with a number of eosinophils as well, associated with here throughout. There's another binucleated one. So more of these kind of larger, highly atypical cells. So what are people thinking of this case? What do you think the best diagnosis is? Is it a thymoma that's B1, a WHO subtype, a thymoma that's a WHO B2 subtype, a B3 thymoma, C, or D, a type A thymoma, or is it E, a Hodgkin lymphoma? Good job. So it actually is a Hodgkin lymphoma, and so these cells here all throughout are actually Hodgkin cells, the Reed Sternberg cells. And so they have this kind of characteristic binucleate appearance throughout as well with these prominent macronucleoli, and then it includes these eosinophils all throughout as well. Good job. And then just to prove it, here's the CD30 that we can see. So diffuse CD30 staining in these larger atypical cells throughout it. Good job. And so our last case here, we have another lesion within the lung here. And then you can see the background lung here. It's relatively well circumscribed. It's not really encapsulated. In the background lung, we can see lots of hemorrhage with these hemosiderin-laden macrophages. See some more hemosiderin-laden macrophages here. And then so here's our lesion here. It has a bit of a papillary architecture. Some areas are a bit more solid. So it's kind of variable growth architecture to it. Often you see the best characteristic histology kind of at the edge of the lesion. And it's made up of a mixture of these more cuboidal cells that are a little bit smaller, and then these larger cells with a little bit more eosinophilic cytoplasm that have a bit more of a round appearance. See here, there's these kind of more cuboidal cells on the surface, and then these more round cells that you can see kind of within it. And it is also some areas of cystic areas, and you see this hemosiderin deposition as well. And then when we look at the H&E, you can actually see we have an interesting staining pattern here where a cytokeratin A1/A3 actually highlights these more cuboidal cells. And then these These rounder cells that we see in the intervenum is actually negative for cytokeratin, but the TTF1 actually highlights both components. So what do you think the diagnosis is best in this case? Is it A, a carcinosarcoma? Is it B, a sclerosing pneumocytoma? Is it C, adenocarcinoma? Or is it D, a carcinoid tumor? Great job, everyone. So this is, in fact, a case of a sclerosing pneumocytoma. So a sclerosing pneumocytoma is a benign biphasic neoplasm that's composed of two distinct cell populations. You have these surface cuboidal cells. They're a bit smaller, and they line these surface areas, and they're cytokeratin and TTF1 positive, whereas the stromal round cells are only TTF1 positive. Well, that's all the cases. I just wanted to thank everyone for joining, and all of my thoughts were with everyone out there in this challenging time. Have a great day.